Historically, the first-line therapy of CLL is chemoimmunotherapy, such as regimens such as FCR, which is fludarabine, cyclophosphamide, and rituximab. And in the last few years, there has been a big shift in how we manage patients with CLL, because there are many different new drugs which are now approved, including Ibrutinib, which is approved in the first-line setting. We have drugs such as venetoclax, which are currently approved in the relapse setting. And then there are many other drugs in the pipeline right now. So the field of CLL is changing quite remarkably, and now in the relapse setting, most of the patients are now actually receiving now new drugs such as Ibrutinib and venetoclax. And there are trials running right now where more and more patients in the frontline setting as well are now being shifted, even in the first line, without exposure to prior chemotherapy, to these new drugs. So that's a big shift, and that's what we're going to discuss at the SOHO meeting in terms of how we are changing the first-line therapy of patients with CLL. Overall, I think the big new information in the last few years has been that patients who are mutated for IGVH, this is a test which can be done in the blood or the bone marrow of a patient with CLL, and if patients are mutated for IGVH, they do very well long-term after receiving FCR chemotherapy. And in fact, in the long-term data which was reported by our group, approximately 55 to 60% at 10 years plus were without any disease after receiving 6 cycles of FCR. So we believe that patients with mutated IGVH still benefit long-term for chemoimmunotherapy, and that's the group of patients we are reserving the chemotherapy. The same data was reported by the German CLL study group and another study by David Rossi, where again they showed that mutated patients benefit long-term. And that's what we are reserving the chemotherapy. If you are unmutated for IGVH, or if you have deletion 17p, or if the patient is older patient above 65 years of age, where they may not be able to receive chemoimmunotherapy, these days those patients we are enrolling them on clinical trials with novel agents or recommending Ibrutinib as standard of care.